Hello, this is Professor Horn. We're going to talk about polycystic ovarian syndrome, PCOS. It is one of my very favorite topics. I'm sure you will figure that out pretty quickly. This is a lecture that I wrote last year, but it is all still current. And since I wrote it, I feel comfortable giving it again. I just didn't record over it last year. Here are objectives they're going to include the entire discussion of PCOS and the lecture. So I've given you some readings, obviously, in your Canvas course about PCOS, but I think it's nice to hear it as well, and hopefully when we are in class, or I can record on a video as well, how I give this talk to patients, because PCOS is a metabolic endocrine disorder. So it involves so many systems. It is the most common disorder in women of reproductive age. It can begin at any time. We do see a lot of this during puberty, especially now that we have younger women, and older girls being overweight. So women with PCOS, they basically can affect their health through their lifespan. And we'll go over all of those things that are included. Quality of life is a big one. So our goal is early diagnosis and then management and counseling. Sorry, I keep saying Classic features, which we'll discuss, is a pretty small percentage, 3 to 7, but under a wider definition, and as far as what you'll see in practice, the number is 20%. Part of that is going to be where you're practicing, right? So the part of the country, the setting, and just your general population of patients. You will find, as we talk about this, that weight is a tremendous issue in any metabolic disorder, but also in PCOS. So if you are in an environment or a population of women who are overweight or have obesity, then you are going to see this more often. When these women were in utero, we think that there could have been some intrauterine factors to play a part. So these are listed there. Potentially fetal exposure to high levels of androgens. And so let's back up for a second. So we have estrogen. We know what estrogen does. We have progesterone. We know what that does. Women do have testosterone. It's a much lower level of testosterone than men have. But testosterone has a lot to do with quality of life for women. And we'll talk about that when we get into menopause next semester. So androgen is, I kind of explain it as like the teenage boy hormone. It is in the, as you know, testosterone is an androgen, right? So it's kind of the male hormone that can get too high in women. And this can lead to a lot of these issues. A lot of these issues can also cause the hyperandrogenism. So when I'm actually explaining this to patients, I basically draw a circle with the, chicken or the egg kind of thing, that it can cause this or it can be in a result of this. I think this is a really good graphic about the signs and symptoms. You will most commonly see women present in the office because, with amenorrhea or oligomenorrhea. So I know that, back in our amenorrhea case study, a lot of you guys chose PCOS. And so hopefully this talk will explain the characteristics of PCOS and how that was different than your case study. So even though it is called polycystic ovarian syndrome, that does not necessarily mean it is an ovarian disorder directly. It was coined by a gynecologist who found these issues as related to menstruation. And so we'll talk about that a little bit as well. A list of associated morbidities listed there. So, weight issues, certain cancers. We'll talk about that as well. They can have pregnancy complications such as diabetes of pregnancy or abnormal glucose metabolism. Women with PCOS also tend to have anxiety, depression, maybe eating disorders. So again, are those related to the things that are going on with the diagnosis, or are they leading to some of those issues? So irregular periods, little fluid-filled follicles, which are called cysts in this particular circumstance on the ovaries, unwanted hair, so that hirsutism, hair loss, and they can have hair loss on the scalp. So you'll see that a lot, thinning or even patches of, some alopecia. They can have a lot of cramping and bloating during menstruation, which is tricky because a lot of them are not menstruating. A lot of these women have acne and other skin problems, particularly cystic acne and the acne that you would associate with menstrual acne, or even teenage acne. And I call it teenage boy acne because that's what it makes me think of. But that really firm cystic acne that's in the epicrine skin glands. So around the hairline, the jaw, down on the chest, the back, the buttocks. So that is definitely a body image issue. Fatigue is a big one, weight gain, and then we kind of already covered pelvic pain. So I do think this is a great graphic, and this is the website it comes from, so you could use that for your patients. PCOS later in life. So this is talking about the morbidities associated with women who have had PCOS in their life. Those obesity rates are higher. They do have insulin regulation issues. They can have hypertension, hyperlipidemia. They're also at increased risk for ovarian and endometrial cancers, and we'll talk about why. So the pathophysiology is, like we said, all metabolic. So related to insulin resistance, hyperandrogenism, and it all relates back to the HPO axis, doesn't everything? So we have an increased pulsatile release of GnRH, which gives you an increased LH and FSH ratio, right? So instead of those being very similar, the FSH and the LH, I don't know why that's written like that. So increased LH, which makes the LH and FSH ratio abnormal. When we have that higher LH, right, so our luteinizing hormone, the androgen production is higher, which makes the follicles resistant to FSH. Okay. So I think this is a good image of what we just said. And because it shows a picture of each part of the HPO axis there. The word cyst in polycystic comes from this. So we're getting that increased luteinizing hormone, right? So increased. But the FSH, so because of that, sorry, let me back up. Lots of LH, which stimulates our follicles, right? Sorry, let me just completely back up, guys. You have an increased GnRH, an increase in luteinizing hormone, and the FSH is lower, which means that the FSH, kind of just this low level, continues to make little follicles, but they never mature because the FSH is not high enough. Okay, so these lots and lots of little cysts there, or follicles, immature follicles, they cause an increase in the androgen level. So you can also think of this as the kind of the breakdown or the conversion of estrogen into androgens, which we really haven't talked about that much, but these are all of the side effects, right, that we just talked about. And then, of course, that feedback to the hypothalamus, and then that cycle just continues. So again, this is basically what we just said, and how those relate to the PCOS itself. In these women, kind of like we said back here at the ovary, right here. So they have a high estrogen level and a high androgen level, right? So all these little follicles start producing estrogen. The increased estrogen level, the increased androgen production does what's called aromatization in the peripheral tissue. So the way that I word that to patients is that, especially when I'm giving them testosterone, that this will, I kind of say turn into, but it will convert into a type of estrogen out in the tissue, which does lead to an increased estrogen level, especially women who are overweight and obese. We're going to, because that estrogen will be stored in their fat tissue. So because that level is high, we get a weird feedback loop happening, which is why we get menstrual irregularities. And as we know, in women who don't menstruate on a regular basis, they have that higher risk of endometrial hyperplasia, which can lead to endometrial malignancy. The high androgens and high insulin levels can have an increased risk of mood disorders. And the way that I kind of think about that is, you have these really high hormone levels. You've got high androgen and high estrogen, which is similar to how we feel in puberty. So definitely those mood, women can feel more irritable because of the androgen. You can feel some sadness or depression due to the high estrogen levels. So it's definitely a part of it. So again, they are typically going to present to you with irregular periods or amenorrhea. And these are some of the symptoms that we mentioned before. They typically have more skin tags. So these ladies might have a lot of little skin tags underneath their arm or in their groin that they want you to look at. They also have the acanthosis nigrinus, which is nigricans, the darkening of the skin around the neck, under the arms, and in the groin area as well. If you think about another population that has that are diabetics, which relates to that insulin and glucose levels. So you can see how that's related. Overweight and obesity is not a reliable indicator of PCOS. Those women I kind of call, phenotypically. So what we see is, an overweight woman with cystic acne, irregular menses, and hirsutism. Those are the most common phenotypes that I see walk in. But you certainly can have a woman who is of normal weight with some of these symptoms that also leads to a PCOS diagnosis. So this goes over, clinical indicators. So what are you going to ask and what are you going to do for this patient? You definitely want to, the hirsutism or the what we call hyperandrogenism or hyperandrogen symptoms, and that would probably be how something is worded, is that excess male-like body hair. So they can have hair on their, we all have peach fuzz on our face. Like that's normal. We're mammals. But they will have excessive male-like body hair. So they may have hair on their chin or neck. Lots of women have hair on their upper lip. They may have really excessive eyebrow growth. And then again, they're going to have hair loss typically on the scalp. They also typically have darker and an increased hair growth on the arms and the legs. They may have what we might consider excessive pubic hair. So that pubic hair may grow up on the belly. They can even develop a line of growth, kind of a thin line of pubic hair up to the umbilicus. And that body hair can be more excessive in the gluteal fold of the buttocks and down in the groin and on the upper thighs. So some things that you just definitely don't want to leave out of a history in someone that you suspect PCOS is a mood disturbance scale. So again, anyone presents to you with irregular menstrual cycles, PCOS is on your differential diagnosis list, no matter the phenotype of the patient, no matter what she looks like coming into you. Just a reminder of what irregular menstrual cycle means, and amenorrhea, okay? So this is a listing of basically what I just described about hirsutism. And I have never scaled a patient this way. I basically say that it's present or not. But this is a scale that you can use to grade your patient's degree of hirsutism. So that can tell you basically, that since it's the most common finding with hyperandrogenism, and the degree or the grade, the scale here is a predictor of that metabolic dysfunction. So this is the scale. Personally, I've never used it, but again, that's what it is and that's what it's used for. There are quite a few hyperandrogenism or hyperandrogen diagnoses that go on your differential diagnosis list, as well as, some cancers and other disorders. Your initial workup, which we'll get to in a minute, is very similar to that workup of, secondary amenorrhea. The PCOS is like a diagnosis of exclusion. So you are ruling out everything else that it could be, and then looking at the indicators of PCOS. So, and you're also in the patient that you suspect PCOS, you also want to rule out any, comorbidities. If she is on hormonal contraception for 3 months, and systemic contraception, which can increase sex hormone binding globulin, right? So sex hormone binding globulin is going to tie up that testosterone and androgen. So you're not going to get an accurate reading of your androgen levels. Fun fact, if you think back to combined contraceptive methods, that a side effect is decreased libido. This is why, because they increase the sex hormone binding globulin and tie up that testosterone, which is generally our sex drive hormone. So, fun fact. So here are some diagnostic lab tests. Depending on your reference, these may be different. So as long as you're generally in this area, a lot of, sorry, I just got a text that confused me. A lot of offices or clinics will have kind of a set group of test results. So when you type in PCOS, as a diagnosis or differential diagnosis, it may give you a lab set to order, or you can develop your own lab set in your EMR. That's how mine is set up, that I type PCOS Mandy, and it, gives me what my options are. A lot of times I will tailor that based on, what's going on with the patient, her age, other presenting symptoms. Maybe she just had a TSH at her well woman exam a few weeks ago, and she's here now because we established that she was having a problem at her wellness exam, and so she's come back to address this today. And let's say I've already done a TSH, right? So I'm taking that out of my labs. That's pretty simple. So here are your recommended labs. So again, we are ruling out TSH, a thyroid disorder, a prolactin disorder, so an anterior pituitary disorder, 17-hydroxyprogesterone can tell us if there's a different type of hormone disorder causing that. Your 2-hour 75 gram glucose tolerance test, of course, is ruling out that just diabetes. She could have overt diabetes, which causes the same symptoms. A fasting lipid and a liver function test, as we kind of talked about, that could be an issue. Again, depending on their age, if they've been seeing their pediatrician and they've had their cholesterol checked, I'm not going to do that again if it was all normal. And then total and free testosterone. So AMH is another hormone that's called the anti-Mullerian hormone. And basically what that hormone is telling you is the ovarian reserve. So when we start talking about infertility, we'll talk more about that. So all you need to know right now is that some people do test AMH in their workup of PCOS, but it is not supported by evidence-based guidelines. It doesn't really give you good information as related to this diagnosis. A transvaginal ultrasound is part of your workup, typically. And it is called a PCOS measurement. So what we're measuring, and you can just order, transvaginal ultrasound is preferred, just like always. In a consenting, non-virginal patient, TVS is the very best option. If you have a patient who just declines a vaginal ultrasound, which is, of course, their decision, you can, or a virginal, or both, you can do a transabdominal pelvic ultrasound. And, each facility generally has guidelines for that, but they need to have a very full bladder to be able to see the uterus and ovaries sufficiently. So there's a threshold for the number of follicles there, depending on, they're going to measure the follicle numbers on both, on either and or both ovaries, and the ovarian volume, right? So the more those ovaries are filled with those little cysts, the more volume of fluid that they're going to have there. So that's a measurement. I cannot stress this enough, that ultrasound is not necessary for diagnosis and is not a single diagnostic tool. So let's say I look at a 16-year-old's ovaries or 45-year-old ovary, actually any woman. We know that our ovaries are developing follicles in the first half of the menstrual cycle. And not, those are typically little follicles until the strongest one survives, the dominant follicle, which then gets, released with our LH surge. So 10 to 25% of females with ovaries, when I look, it could look like polycystic ovaries, right? So they could have lots of little cysts that are associated with the menstrual cycle. Or, it could be a woman who has maybe missed a period, or her periods are just irregular, but not due to PCOS, if that makes sense. So just because you see PCOS on an ultrasound, do not jump to that diagnosis. And I will explain why. So there are guidelines for diagnosis of PCOS. So just like think about your think about your BV criteria, right? You have to have a certain number out of the certain number. So we have the same thing for PCOS. This is the Rotterdam criteria. So again, with diagnosis, with identification of this specific phenotype that I talked about, so what the patient looks like. 2 of the 3 criteria must be met for diagnosis. So if she has number 1 and she has number 2, you do not need an ultrasound, right? If she has one of the other 2, then you do need an ultrasound to make a diagnosis. Sometimes you will have number 1 and all of your number 2 labs are normal or borderline, and so you would go ahead and get an ultrasound. So this is what I was talking about with the phenotypes. This is a classic presentation. So sorry, that's kind of blurry as I blew it up. Hyperandrogenism, anovulation, PCOS. Polycystic ovaries. And type B is pretty classic. So you could see hyperandrogens, anovulation, and not the polycystic ovaries. These A and B are the most classic, and they have higher incidences of the other dysfunctions. These are the other 2 types, so kind of talking about what you may and may not see in your lab results. I have seen this. I've seen this on occasion, but not this a lot. But again, A and B are your classic ones. So your management must be guided on like what the patient wants. What are her goals, and what are our goals for her as far as health and wellness. The purposes are listed there, right? We want to decrease those androgen levels, protect the endometrium, improve menstrual function, which will protect the endometrium. We want to improve that metabolic status and improve fertility if she does want to become pregnant. And this is kind of, everyone is different, and we need to figure out what the person wants. So, the first question is, okay, let me flip to the next slide and make sure I'm not getting ahead of myself. So, what are your goals? What bothers you the most about this? And you start with that. So if she says, I want to be pregnant, I've been trying to get pregnant for a while, then that is going to guide your management in that way. If her concern is, I have all of this hair everywhere and acne, and it's causing me a lot of mood disturbance, I don't want to leave the house. Again, that's our focus. We still have to do all of the things on this list other than fertility, if that's not the case, but all the things here on this list. But I do feel like in shared decision making, knowing what the patient's goals are when she presents to you, if you start with those goals, right? Unless there's literally something that you're truly worried about, right? So let's say she is perimenopausal and you are concerned about her endometrium and she's concerned about her acne. You need to work together there. I mean, those are certainly two things that you can do at the same time: evaluate her endometrium and start working on her acne. But if you can talk about, okay, these are I understand that, express that understanding and empathy, because as people, women or men or non-gender, as people, our face is what we present to the world. And when we have facial issues, facial concerns, that's not something that you can generally, in the Western culture, hide. We can put on long sleeves. Not everyone is seeing our chest, buttocks, all of that. But your face is what you present to the world. So that is, again, that's often the woman's concern. If she's not trying to be pregnant, her concern is not necessarily, depending on the patient, not necessarily going to be that she's not having periods. Some women are like, yes, that's great. That's awesome. I don't want to have periods. But we know medically that can be a concern. So you have to show her the entire picture of what's going on. These are your summary of recommendations and conclusions by ACOG. Again, I'm not going to read all of that, but I'll kind of go over highlights. Nutrition and exercise, just like we know with diabetes, can lower those circulating insulin and glucose levels, which has to do with the second one, which is insulin sensitivity. Letrozole is the same, someone who wants to get pregnant. So infertility, which again, we haven't addressed, but letrozole is better than Clomid. So Clomid is probably a word you've heard from someone's friend or sister had to use that. Laser hair removal and efflornine is better than laser hair removal alone. Unfortunately, once the hair growth is there, you can't medically do a lot about it to make it go away. So unfortunately, these women are, the legs and the arms, they're going to have to shave or want to shave more frequently. Laser hair treatment is not cheap. So that is, those are decisions that the patient unfortunately is going to have to make on her own. We've talked about this reduction in body weight. In a patient who does not want to be pregnant right now, for long-term management, and again, it's only a level C recommendation, but it is the most common method. So a lot of times these women are going to be put on a birth control pill and something like metformin. So even though, if the woman is not diabetic, it is a very good management tool for PCOS, and you will see that done a lot. So a low dose hormonal contraceptive is going to be your best bet. So something like a, low estrogen, a 10 microgram pill or 20 microgram pill of estrogen, because we already know that her estrogen and sex hormone binding globulin levels are high. We don't want to make those worse initially. So that's a really good option for those who don't want to become pregnant currently or in the future. And we've already talked about this. Sorry. So the 17 hydroxyprogesterone value is what is ruling out that congenital adrenal hyperplasia diagnosis. Again, typically a woman who is a young woman who's presenting to you, if she has had medical care with her pediatrician, this is typically going to be something that has already been diagnosed. And there's really, again, there's no primary treatment for that hirsutism. You can use spironolactone for acne. It may or may not be helpful. That is a form of diuretic, so you do have to be careful with who you're giving that to. And someone who is a heavy exerciser, which is going to be rare in a PCOS patient, but or someone who does not hydrate well, which is common in young women, you want to be careful. And back to the oral contraceptive, a lot of providers will go right to Yasmin. I can't think of the new one. So one of them that has, drospirenone in it, which is a, cousin of spironolactone, which may help with acne. Now, any combination contraceptive, it should help with acne. So, the Yasmin, that family, those are only 30 and 35 microgram of estrogen pills. So, so to get to that low dose, you're going to lose that option of drospirenone. Okay. So again, here are the keys: correct early diagnosis, assessment for comorbids, education, shared decision-making, and using that evidence-based practice management. And steering them away from TikTok is a big one. All right, let me know if you have any questions.